Hello, my name is Dr. Benjamin Unger, and I'm a dermatologist at Mount Sinai, New York, and I'm joined by Professor Dermatitis, a dermatologist at the University of Lübeck in Germany. Today, we'll be discussing the treatment of moderate to severe atopic dermatitis in children and adolescents and sharing insights from our own clinical practice and experience. So we'll begin by understanding and assessing disease severity in children and adolescents with atopic dermatitis. So it's very important to remember and keep in mind that there's a significant and tremendous symptom burden in pediatric populations with atopic dermatitis. Perhaps forefront and central to this is the chronic pruritus that pediatric patients with AD experience. And not only is the pruritus itself impairing in terms of quality of life and so on, but there are downstream effects as well that really have a tremendous negative impact on their lives. One of the central components to this is the sleep disturbance that accompanies the pruritus. These kids can't sleep well because of the itching, and this has effects in many domains in their life. Overall quality of life, cognitive impairment, psychological stress, their impaired family relationships. Children who don't sleep well mean that parents don't sleep well. This is accompanied by poor self-esteem, poor school performance, emotional, behavioral issues, and all of these combine to really have an effect on the children's life and the whole family's life. The symptom burden with AD is often particularly significant for patients with chronic hand dermatitis. It's important to keep in mind that when we're treating these patients, we're treating not only the visual aspects of what we see on their skin, but all these different aspects that are accompanied by the disease, and with the goal of really helping the overall quality of life and improving all aspects of how they live their life. Now, Diamant, let's take a look at some questions submitted from our audience about how to understand and assess disease severity in children and adolescents with moderate to severe atopic dermatitis. So the first question we were asked is, what do we currently know about the impact of AD on quality of life in children and adolescents, especially in terms of activities of daily living? Does this change according to whether or not the hands and feet are affected? In your clinical experience, what aspect of quality of life affects these patients the most?
Benji, you mentioned already that especially in children, there's a big impact on the quality of life, and not only in the children and adolescents, but also in their parents. I think if the visually areas like they are, for example, visible, like hands or face, it's also very important that if the patient have involvement of these areas, this might have a big impact in the quality of life of these patients, especially the children are not very diplomatic. The children usually, if they see that one child is having something on their hands, they don't want to play with them. And I think this is of particular importance for our patient, for their friends, but also for the families. And the quality of life of this patient, it's really impaired in, let's say, adolescents, 80% of them, also 2/3 of the small children playing with or meeting other friends, for example. And if you ask this adolescent or also the children how confident you are about how they look, for adolescents it's very important that they have no signs and symptoms of atopic dermatitis. But also for children, school-age children, this might be also very important, especially if you ask them how are you doing in the time that you have flares, for example. Is this somehow impacting you? Things they are doing at home. And adolescents, 80% of them, they're mentioning yes. And in children, it's 3/4 of the patients. So it shows from the just recently published data how the quality of life is impacted in moderate to severe patients with atopic dermatitis. And this correlates very well with the disease severity.
So I'm going to move on to the next question about this discussion, which is, can you tell us about any other considerations when trying to understand the symptom burden in AD? For example, how important is it to monitor and support the mental health of children and adolescents with moderate to severe disease and also of their caregivers?
In my personal opinion, it's very important that we have a talk to parents and also to children. I think in adolescent it's also very important that we have also select the adequate wording to that, what we are mentioning. But the caregivers are telling us that, let's say 10% of the patients, they have more than 15 days impacts on the mental health. Then 1 to 5 days, let's say that more roughly half of the patients are mentioning that they have impact on mental health. So it's very complex. In one side, we are talking about how can we avoid provocating factors, trigger factors. The other side is also very important to understand the disease. I mean, nowadays it's much easier to talk to the patient, also to the children, to measure the quality of life with the different methods that we are using, to ask also for itch, to ask for the pain, to look for the skin, is it dry or not. So I think it's very complex. However, it is mandatory that we look carefully and also take in consideration how the children are behaving. I mean, these children are very active, it's no doubt. However, if they are very active, this might make also trouble because they cannot concentrate while they are doing the school or doing the lessons or homework or whatever. So I think it's a complex, it's very important that parents, friends, and also patients understand this.
I completely agree, and I want to pick up on one point and add my perspective, which is that these effects are incredibly common, but patients and their caregivers don't always know or really have the wording or the kind of context overall to really put this into words in the visit. And I think that bringing it up, discussing, eliciting, asking about them helps them to realize that this is not unique to them. They're not doing something wrong. This is part of the disease, and our goal in treating them is to help these aspects as well. So the next question on this topic is, I find the number of different severity scales for AD overwhelming, and several are either time-consuming or not very accurate. What are the best assessment tools available to help HCPs assess and understand disease severity in children and adolescents with AD? Which ones do you find most informative and practical, and how do you choose between them in your own practice?
Benji, you have mentioned this. It's a little bit difficult question. It depends where you are. For example, if you are in US, you will probably do more easy or investigate a global assessment. I think global assessment is really easy to do and everybody can do it, and it's something part of that even pediatricians and dermatologists are doing. In Europe, we'll likely be more scored, which is very specific for Europe. I think it's important that whatever we do, we have to have one assessment of the quality of life. Either we do the DLQI, POEM, or whatever. So first thing, I think to capture the disease severity, we need to know the impact on the quality of life. The second are the subjective symptoms of the patient. Whatever scale you are using, the visual or analog scale or numeric rating scale, understanding the itch, impact on itch, it is also important. It's a peak pruritus or an average, whatever, but it has to be constant. And the third one, it is also analysis of the signs and symptoms of atopic dermatitis. How is about the rashes? What about the excoriation, infiltration, papulation? And for this, I usually do in a daily practice score. For academic reasons, to be consistent worldwide, we do also the easy score. However, you need to select one which are more familiar and where you have no problems on repeating this. Sometimes it's also nice to know the body surface area involved, and whatever you do, it is very good if you do constantly the same methodology. Not today, easy, and after 2 weeks you do the squat, because then we will have a problem.
Absolutely. Certainly in terms of the ease and quick ability to implement a tool, IGA is very quick. We know mild, moderate, severe disease, when we're treating these patients, doesn't capture the whole kind of a spectrum of the disease, and that's absolutely where those subjective and symptomatic assessments are so crucial. And certainly in the US, really documenting that, identifying the disease severity allows us to get patients on the appropriate medications. So how important is patient or care physician communication in understanding disease severity and treatment needs in AD? How do you talk to patients about this? And do you approach conversations any differently when visible areas or areas that are of most concern to patients are affected?
I think it's very important once you are discussing to adolescents or school-age children or other children to understand also the disease. That some of these children and adolescents, they come in the time of a flare. In a flare, it's much easier to discuss about the disease severity. But atopic dermatitis is a different disease. Atopic dermatitis is disease which has a chronicity, goes with ups and downs, and it might happen in the time point that they have made a point when they had a very severe disease. And suddenly you see let's say in front of you a patient with a mild to moderate, but not mandatory, and a severe one. But nowadays it's not bad. If they document, you see the pictures, and then you try to find out what is a really disease activity. I think it's also very important to ask how many flares they have. I think this is also important if you cannot see in front of you, the patient is not really showing extensive redness or infiltration in population. And it might be that the patient is well treated, well topical, it was partially effective. So it's very important to understand also the needs of the patient. And once the patient are mentioning that the visible areas are involved, and we see this, I think this is very important. And if the hands are involved, I think this is having an additional impact. I think it's not only from the visual aspect, but also from a functionality. They cannot play, they cannot work, it hurts also. And it is also the way how they spread also potentially bacteria from one part to another part. So I think it's not only from the cosmetic point of view, but also functionality and also disease aggravation. It's very important that visual area, especially the visible area like hands, are well under control.
In this second section, we'll be discussing considerations for the selection of systemic therapy for children and adolescents with moderate to severe atopic dermatitis. So to start with, I want to review the approved systemic therapies for moderate to severe atopic dermatitis in children and adolescents, both by the FDA and the EMA. So the FDA has approved dupilumab, which is an anti-IL-4 receptor alpha monoclonal antibody to treat adult and pediatric patients aged 6 months and older, and tralokinumab, an anti-IL-13 monoclonal antibody in the treatment of adult and pediatric patients greater than or equal to 12 years of age. Both of those monoclonal antibodies are also approved with the same indications by the EMA, with the additional approval of lebrikizumab, a different anti-IL-13 antibody in the treatment of adult and pediatric patients aged 12 years and older. The FDA has also approved 2 oral JAK inhibitors, abrocitinib and upadacitinib, in the treatment of adult and pediatric patients aged 12 years and up. Similarly, the EMA has approved both of those medications with the additional approval of baricitinib in the treatment of adult and pediatric patients greater than 2 years of age. There's additional agents used off-label for systemic therapy in pediatric patients, including traditional immunosuppressive broad-acting medications like methotrexate and cyclosporin A. So Diamant, let's take a look at some questions submitted from our audience about what we should take into consideration when selecting a systemic therapy in children and adolescents with moderate to severe atopic dermatitis. The first question is, can you tell us more about the challenges with basic skincare and topical approaches in managing moderate to severe AD, particularly in children and adolescents?
I think in children and also in adolescents, it's very important that we teach them, we educate the children and also the parents. There is some need for application of the basic treatment. And this basic treatment with emollients have to be adapted according to the skin. Sometimes the parents use very oily and very greasy ointments, and this might be counterproductive because a very greasy and oily ingredients may somehow provocate or even worse atopic dermatitis in children, especially in infants. This might be an issue. But I think what is also important that they have to understand that the skin is dry and the dry skin need to be moisturized. Otherwise, it might be also a risk for the occurrence also of more infection. And I think the patient understanding now. It's also very important to select an appropriate emollient because emollients can also be a source of, let's say, contact allergies. Emollients can be source of the bacteria. If they put the fingers, for example, inside and they take the same emollients from the same bottle and then they're infecting, putting from the skin and then putting again in the bottle there, and then the bacteria may be also incubated there. So I think it's very interesting and very important to understand the importance of the right selection of an adequate emollient and the basic treatment.
That's so true. One thing that I want to add, is that topical approaches can certainly make a difference in managing moderate to severe AD, but sometimes they're not enough. And I think one of the challenges is understanding, from the patient's perspective, the parent's perspective, when that, the threshold has been crossed and when the topical treatments just aren't enough, and understanding, kind of introducing the idea of a systemic treatment. And there's no right answer to that. That's a conversation that can be challenging to have, but I think it's important to keep in mind as well. Okay, so we're going to move on to the second question, which is what role can systemic therapies play in addressing the challenges with basic skincare and topical approaches to moderate to severe AD? When is the best time to initiate systemic therapies, and what treatment goals are important?
To my personal knowledge, it is extremely important that we are also telling to the patient that if they are not responding to the topical treatment, they're candidate for the systemic treatment. I think that as a dermatologist, sometimes we are trying, especially to deal with the children and their parents, they are prone more to do, postpone this, do another topical treatment, do you have another topical treatment? And finally, the area, it's more, the body surface area involved, if it's large, then this might have also systemic effect. I think it's a need to say to the patient, we need to treat disease activity adapted. If the patient are having a moderate to severe disease, not able to be controlled with topical treatment, this is the time that we have to consider also the systemic treatment. I know it's difficult. I know that the parents sometimes do not accept. I know also the children are not always willing to get injection or to have some tablets. But I think as earlier we can introduce the systemic treatment, we have a better chance also to prevent and avoid lichenification and chronification. And ideally also to prevent the occurrence of comorbidities in the future.
I absolutely agree. In the first section, we discussed the impact on quality of life of untreated atopic dermatitis. And I think it's important to keep that in mind when we're treating patients. The goal is to really help them have an improved life, both from the visual perspective, the impact on all kinds of domains in their life. And if it's necessary to, kind of advance the systemic treatments, that's a conversation that's important to have to really get to that goal. But we shouldn't be shy about having the conversation about systemic treatment when it's necessary.
And also mention that we are so happy that in Europe we have a slightly more systemic treatment. In topical treatment, in the US, you have much more treatment options. In Europe, through EMA, we have a little bit more biologic, also one more JAK inhibitor. And I think this is also nice if you have more in a treatment armamentarium. But that's what is also important, that has to do also with the safety profile. Especially in children, that's a big concern. The parents, which are coming, they're not asking us how effective the treatment option is. It's usually how safe is the treatment option. And then we discuss. And I think from a clinical trial point of view, we have realized and we have a safety profile which is well established among the biologics, among dupilumab, tralokinumab, and also among newly introduced lebrikizumab. And with the JAK inhibitor, also always the question, how safe it is, can I give it to my patient? Would you consider this one? What is about the safety profile? And we can say that regarding that, what we have seen from the latest data, which have been presented at the conferences like American Academy, but also at the EADV, I think it showed that that what we have seen in a clinical trial, also in the real world data, is also very reassuring. What I think it's also very important for our daily practice is that also children tolerate the treatment option as good as in a clinical trial. If not, sometimes even better. So I think this is also something that we have learned just recently from the most recent data, that tolerability and also safety profile that was seen in the trials is also in the daily practice very similar. For example, with biologics like dupilumab, we still see conjunctivitis in this patient, but the conjunctivitis is, I have an opinion, it's more milder. It's easier to manage in children and adolescents especially. Regarding the JAK inhibitors, I think it's very individual. Some patients still prefer, let's say, an oral treatment option, and we have to be cautious how can we minimize eventual risk. But I think this is very broad, and the most recent data are showing that they are very reassuring that we can introduce the systemic treatment also to adolescents and also pediatrician.
So the third question is, in terms of patient suitability for systemic therapies, what are the key considerations when selecting appropriate treatment for children and adolescents, including the impact of prior non-systemic therapies? How can we incorporate the lifestyle needs and the preferences of patients and carers into the treatment decisions?
In patients with atopic dermatitis and also their parents is not very easy, because you are treating all the family and their friends together. And I mean, this necessity of the systemic treatment, it is very important once we are trying to tell them that benefit and risk are much higher if you are, for example, intervening with a more potent treatment option. And I think this understanding benefit of the treatment and also taking in account the risk that we have with the systemic treatment, as better the ratio is between the benefit and risk, I think it's much easier not to convince, but also to make a shared decision with the parents and children together, and also with adolescents, because I think there is no other disease where we need this shared decision. Otherwise, there will be no treatment success at the end. And preferences of the patient are of particular importance. But we have to be very careful how we are introducing the treatment option, because sometimes the perception is different. Patients have the perception that topical is the safest one, not mandatory. If you apply topical steroids of very high potency in 90% of the body surface area, this is like you are having a topical and oral corticosteroids. But I think this really matters. Understanding how much can we offer to the patient, how much can we improve in a short period of time, and that we arrived at that stage that topicals are not enough to control all the signs and symptoms that the patient are having.
Okay, so moving to the next question, how can we monitor treatment response or treatment responses with systemic therapy for AD in children and adolescents, including for outcomes that can be challenging to monitor, such as skin integrity preservation, scarring prevention, or post-inflammatory hyperpigmentation?
It is very important once we are putting the patient on the systemic treatment. Depends if they receive a biologic like dupilumab or tralokinumab or lebrikizumab or JAK inhibitors. It's very important that we do a very proper screening of this patient, looking who is eligible for which treatment option, exclude any potential risk, minimize the risk of an adverse event, and how can we introduce this as early as we can do. And today, I think what we are realizing that by treating systemically, we are also improving the skin barrier. And the skin barrier is, at the other side, very important, because this is sometimes also the place where we get the triggering of the disease. With dupilumab, the data have been presented where we see improvement of transepidermal water loss, where we see also improvement of the signs and symptoms like EASY, or we see also improvement of the itch in this patient. And I think these are very crucial also studies that have been performed showing that improvement of the skin barrier is done by the improvement of the immune system. That is not inside, outside, outside, inside, but it's both. Improving the immunology in this patient, we are improving also the skin barrier. I completely agree. At the end of the day, it is important to think about, skin barrier, post-inflammatory hyperpigmentation, all of these, components of the disease. But there have been a number of studies that have evaluated this, and ultimately when the disease is well treated, all of these components improve as well. And so when we take a global approach and thinking about, are we really adequately treating patients, I think we can have the confidence to understand that if we succeed in, the measures that we discussed, as you said, EASY, IGA, the patient-reported outcomes, then ultimately all of these things will improve as well. And what I realize in my daily practice, the patient, especially adolescents, sometimes are prone to use twice, 3 times, 4 times daily, even emollients. And once you see that they are improving, then I ask them, how frequently do you use a basic treatment? They say, oh, I use it occasionally, 1 to twice per week. Then you realize, okay, this is also improved. But I think monitoring of the skin, monitoring of the signs and symptoms, looking also for the patient-reported outcome, it helps us in understanding how good we are controlling the disease how we are treating with the systemic treatment.
In this third section, we'll discuss practical management of side effects of systemic treatments for moderate to severe atopic dermatitis. So when we think about the notable side effects, common and side effects and risks that we need to really consider when using these treatments, typically we separate them out into the 2 categories of biologics and JAK inhibitors in the treatment of AD. So in terms of the biologics, dupilumab, lebrikizumab, and tralokinumab, the 2 really primary side effects that we see are conjunctivitis and injection site reactions. In the vast majority of the cases, neither of these are very significant or severe. They tend to be more mild, but are ones to be aware of and consider as well. In terms of the JAK inhibitors, there are a range of different common side effects and then some safety considerations that we need to think about. So when looking at abrocitinib, the most common side effects include nausea, acne, perhaps a little less common than upadacitinib, and upper respiratory tract infections, herpetic infections, and headache. For baricitinib, the two most common side effects include headache and upper respiratory tract infection, as well as herpes simplex infections. And then lastly, with upadacitinib, acne, as I mentioned before, as well as nasopharyngitis, upper respiratory tract infections, herpetic infections, and headache. So you may see a bit of a trend there in terms of the relatively common side effects to think about. Now, there are additional considerations, including monitoring for abnormal hematologic counts, increased lipids and creatinine phosphokinase levels, although typically that was not really clinically significant in the trials. There is a boxed warning by the FDA and PRAC recommendation by EMA for JAK inhibitors as a class for a theoretical risk of malignancy, cardiovascular disease, thromboembolic events, and serious infections. And so certainly when you're thinking about discussing, initiating one of these medications with a patient, it's important to consider whether they have any risk factors or prior medical history that would increase the risk of any of these outcomes further. Okay, Diaman, so let's take a look at some questions submitted from our audience about the practical management of side effects in our patients with atopic dermatitis being treated with the systemic therapies. So the first question is, I would like to know how to identify the side effects of systemic therapies early in my pediatric patients with AD. Are there any recommendations for routine monitoring the patients taking a biologic or JAK inhibitor? And how does the monitoring differ according to the agent?
Yeah. But I think it's very important once we having the patient to identify the right candidate for the right treatment option. For example, if the patient is having a very dry eyes, from the beginning I'm trying to prevent the occurrence of conjunctivitis, because conjunctivitis might be also prone of the itch, and if conjunctivitis is occurring, for example, with biologic like dupilumab or lebrikizumab, we are trying also to treat them very early. So the first visit that I see the children usually is after 4 weeks. I can prevent this, I can treat this very early and adequately, and there are only few patients who are not able to tolerate this. Regarding the JAK inhibitors, I think we need a little bit more careful selection of the patient. It's not about the efficacy, it's more about minimizing eventually risk of the patient that might have. And I think with the JAK inhibitors, it's very important to prevent the occurrence of this adverse event, for example, by a proper screening, avoiding usage in the patient who are having very frequently also infection, patient which had a chronic inflammation in the past, chronic infection in the past, like hepatitis B and C, excluding TB. So it's a little bit more paperwork to do, but the monitoring is very individual. In some patients, you might need a close monitoring because they might tolerate a little bit, they might have some adverse event that you need to closely monitor. In some others, you will not need this because you have to individually adjust and individually adapt. With the biologic, the beauty is that you don't need a lot of monitoring.
Absolutely. I certainly agree with everything you said. There is an individualized aspect to the monitoring, and so there's no blueprint or one size fits all to say, here are the time points at which you monitor blood work. I think a good rule of thumb is that, if they're lower risk for certain outcomes, then monitoring initially a little more frequently and then spacing out the monitoring thereafter, maybe, at the 1 month mark, 3 month mark, and so on, and then separating it out can be helpful. But if someone needs more frequent monitoring, then, that's the path we take, understanding that if that's the right treatment for the patient, we do what we need to. So moving on to the next question, one of our audience asks, do you have any advice on how to best manage the side effects of systemic therapies for AD, such as conjunctivitis, nasopharyngitis, acne, and infections? Are there any circumstances where I should refer the patient to another specialist?
I mean, a lot of patients may have conjunctivitis at very early beginning. So I think moisturizing eyes is very crucial. If you see the dry eyes, it's very important that we are trying to prevent this. We are trying also to adjust the dosage probably, and also to convince the parents and also the patient that later on we might have also silencing of the conjunctivitis. I think the nasopharyngitis is not an issue with biologic. It's mainly occurring under the treatment with JAKs, and sometimes if the patient have an acute infection, we need to stop the treatment with the JAK inhibitors. And I think also the acne, it's more prone of the upadacitinib and less with the other JAK inhibitors. However, to my personal opinion, this is not a typical acne. I'm trying to explain to my patient and also to the parents, this is a JAK-acne, the JAK-specific acne, which differs, but it's usually easy to manage at the early beginning if it's treated properly. Sometimes you might need a systemic treatment, and sometimes it is so severe that you have to stop the treatment. But I think it's very important that we adjust this. And finally, what is also very important, if you're not allergologist, it's always good in the time that the patient are doing well that you exclude something which is aggravating, because this might be very crucial for the selection of the treatment option that we are having for our patient.
Absolutely. And, I think that you had mentioned this, I think a few times, and I certainly completely agree that usually the kinds of side effects that we're talking about tend to be on the more mild side. Definitely when it's more severe, that's a little bit of a different story, and often specialists in those circumstances can be helpful to hopefully, address the side effects while also making sure that the AD is well controlled.
I think it's very important if the patient are having an infection. Skin infection are very common in atopic dermatitis. It's only contamination is not a problem. But if they are having really a severe skin infection, it might be the systemic treatment is needed in this patient. So I think in that time, for example, if the patient are using the JAK inhibitor, they have to interrupt the treatment first to treat infection, and after recovery, they can restart the treatment, for example, with the JAK inhibitor. So I think JAKs and also infection, we have to be cautious. Especially, I think it's a big caution regarding the viral infection. So patients who have prone to have more herpes simplex infection, I'm very cautious in introducing to them JAK inhibitors.
So our next question from the audience is it safe to continue systemic therapy for a child with AD indefinitely, or should treatment be given intermittently or tapered depending on disease control? Is there any evidence on the benefits and risks of long-term systemic therapy?
I think what the parents and especially children, they don't like if you tell them, oh, this is lifelong treatment. Nobody likes, even if you will be my physician, you will tell me, look, this is a treatment, you have to take it to lifelong. I will be not very happy about this one. So I think we can say, okay, we need it at the moment. In the children, we are very lucky that probably we are dreaming about this, that probably at a certain point of time we may stop the treatment. We don't know at the moment, but we may stop the treatment. I think with immunosuppressive in the past, we have done intervention. I think still intervention with JAK inhibitors might be also rational, 3 to 6 months. But with biologic, I consider the patient that I need to treat them in a long-term run. And today we have excellent data showing with the biologic like dupilumab and also tralokinumab efficacy also was well shown in the clinical trial, but also in the daily practice, showing that the signs and symptoms can be controlled by months and years even. And also the JAK inhibitors have been suitable and designed, to be honest, to be given in a long-term run. And I think this is the benefit that patients who are selecting are mainly patients not really moderate, more severe than a moderate. And in this patient, usually we need a good control of the symptoms like itch, for example. We need a skin clearance, and even we can raise the bar and look for clear, almost clear skin. So these are the systematic reviews and updates from the EADV and also for American Academy have shown that this is even possible.
Absolutely. I think at this point, there have been an overwhelming number of studies that show that these treatments can be effective over the long term. And so when you have treatments like this that are effective and well tolerated in the long term, I think that's kind of the framing that often helps in treating patients, with the caveat in mind that you brought up. It's not that these people are going to be on it for life, but it's kind of the medium to long term, and we kind of adapt as we go as the patients progress. The next question that our audience asks is, I find it very challenging to encourage patients on JAK inhibitors who are experiencing side effects to adhere to or not stop their treatment. What strategies do you use to motivate patients and their carers to continue with JAK inhibitors despite the side effects, especially adolescents who are impacted socially and psychologically by acne?
And I was as a clinical investigator in different clinical trials, and I was wondering at that time point, how can it be that they have such a good treatment adherence? And I was very good to my patient, and I asked one of this adolescent patients, are you really sometimes skipping the treatment? No, I'm not skipping. How can it be? If you are taking the drug and you forget 1 or 2 days that you don't take, for example, a JAK inhibitor as a tablet, then the efficacy is going very fast down. They get a very fast experience of the itch, and they don't want to have it. So I think adherence is not an issue in patients with a JAK if they want to control signs and symptoms, like, for example, the itch. The problem is really indeed on that you mentioned, okay, we have to interrupt the treatment because of infection, because of an adverse event. We have to adapt the dosage, for example, in the certain patient, or we have to add something else. And I think this social and psychological adverse events which are curing, for example, with acne. One of the patients came, he had 2 spots, and he said, oh, it's terrible, but you had 90% of the body surface area involved with atopic dermatitis, and now 2 spots of acne are making you a problem. But, I think it's good that you really consider this small consideration of the patient. If any adverse event occur, manage them appropriately and discuss with your patient. Understand their needs and also their thoughts in order, it might be that what is very important for us is totally unimportant for the patient.
Okay, so our final question is, if my patient with AD is not responding well to systemic therapy or is experiencing side effects, should I discontinue the treatment, or is it possible to switch to a different one? How do I know when to switch, and what practicalities of switching therapies do I need to consider to optimize the patient outcomes?
Oh, this is a difficult question. This is not really very easy question. But to my perspective, it's always, I'm trying to stuck in the treatment option that we have, that I've selected. So lemon squeeze tactic, trying to find out is something aggravating, and I would like to be really sure that the treatment is not responding. It's different if an adverse event comes, an emerging adverse event where I see, okay, I cannot continue the treatment anymore. So, but I try everything in order to manage the adverse event. And if not, I'm not postponing this, especially if the patient have not achieved the treatment goal that I want, and a minimum of 50% improvement. Or the patient are using the treatment option since 6-7 months, and they are a little bit improvement, the minimal one. I am not happy with that one. I think this is also expectation of the patient, and my expectation sometime has to meet together. And if we have no treatment response at a certain point of time, we must agree for the next treatment class or next treatment option. And the problem is, which should I select? Should I stay within the same class? Usually we select the different class. And in the switches, I think it's a very practicability is very important. Keeping the previous treatment, introducing the new treatment, it is something that, especially from immunosuppressive, are very important. Sometimes we forgot that if you stop the immunosuppressive treatment and you introduce suddenly, let's say, biologic, we might have a gap that the patient may fall down. So biologic treatment usually needs a little bit more, 3 to 6 months, in order to have the full range of response. And with JAK, it happens that it is much faster. So it depends what we would like to achieve in which patient, what is important. However, the vast majority of our patients, 3/4 of them, they start usually first on a biologic, mainly on this balance of efficacy and safety profile.
Yeah, no, and I think one additional, consideration, or that I think about at the very least, is, that if someone's not improving at all after, a number of months, then it's probably suggested that they're not going to improve. But if they are improving slowly, it may just be an issue that they take longer. And, we don't want to rush to change treatment, as you said, squeeze the lemon out to say, okay, sometimes maybe we just need to give it a little longer. Thank you for your attention. Thank you to Professor Thatchy for joining this discussion on optimizing treating moderate to severe atopic dermatitis in children and adolescents. And thank you to the audience for watching. We hope it has been useful and informative for you.